The next session would be on drugs and developmental disorders by Dr. Jeeson Unni, Vice President, South Zone IAP. And I now request a chairperson, Dr. Narmada Ashok, Senior Consultant Pediatrician and Allergy Specialist from Vellore, to take over. I request the chairperson to occupy the dais and the speaker to occupy the podium.
Allowing me to chair this very important session for Dr. Jeeson Unni, whom I've admired from the days of from my PG days, looking at his textbook, and sir as the main person who has done the pharmacopoeia of Indian pediatrics. So this is something which is a reference for all of us in our clinic, and I'm very happy to chair his session. And as we know, the drugs in developmental disorders is again one of the topics which is of quite contempt. So we pediatricians, whenever we see a drugs in a child with a developmental delay, we are little skeptical. And then this child, when it comes to a practitioner, we are also again wondering how to continue that, how to give along with the drugs, what is going to be the effects of the same. So I'm very sure sir will give us a very detailed knowledge about the same, sir. Over to you.
Hello, good afternoon. It's great to be here in Chennai. I thank the organizers of the conference, Dr. Subbu and Dr. Sudhakar, and the GDP officials for having invited me for this talk on medications in NDD in children. It's a huge topic and you can't complete it in 20 minutes. So I'll be maybe talking only about ADHD and its management, because others are, it is about 59 slides. You know, if you go through the whole thing, it will never finish in 20 minutes. So next slide, please. Where do I have the... So these are the conditions which you'll require medications, a huge list. So when you principles of pharmacotherapy is that educate, mainly it's counseling. You have to counsel patients and their families about how to use these drugs. What's the goals of these medications? How do you tell them that it is not going to be curative, it's going to be just treating a part of their disease. And never trust medications on patients. Always tell them what is the goal of therapy, and a trial can be given only after they accept that this medication can be used. So that's something that we must ensure. And you be supportive of other management tools, because most of the management tools are more important. Drugs are a very small portion of the treatment of NDDs in children. Always begin with a slow dose and gradually increase the dose. That will reduce complications. That's important. And you know, the medication might change as the child emerges into adolescence. That's important. And you must share responsibility. Each person should know what is required for that particular child. Now, behavioral disorders, there's so many things that we can discuss. Before medicating any child, confirm diagnosis. So very important that you have a diagnosis. And counseling, as I said, is most important. And medications that fit needs to be part of a plan, and that includes other therapies. Other therapies should be continued and medication should be added on. It may not cure, as I've already mentioned, and informed consent is absolutely important. So what are the conditions, what are the things you think about when you're giving medications? What medication being used? What is the time bound for these medications? How long do you give this medication? How does it work? How do you administer the drug? What are the interactions? Basically, a pediatrician should know exactly about each drug. That's why a formulary is so important. Every drug, you need to know everything about the drug. How do you know whether the child is better or worse? Clinical labs, monitoring, and how long would the medication be given, and how do you prioritize medication depending on the condition of the child, and when do you stop? So these are things that we'll discuss over time. So we'll be mainly discussing medication for ADHD, and there are others we'll see. If we have time, we'll talk about ASD also. So in ADHD, again, you have to have a diagnosis for sure, and you should have the grandparents, parents, and the child involved in the counseling. And if they are practicing any other methods, non-pharmaceutical methods, congratulate them for that. And inquire the results of the methods used and how they ensure compliance to those methods. Inquire home situation about siblings and about previous medications, if any. Now, what is the most commonly used medications in children with ADHD? One is stimulant, that's methylphenidate, and the other is a non-stimulant, atomoxetine. Everyone knows about it. What is the mechanism of action of MPH? It blocks the reuptake of two neurotransmitters, norepinephrine and dopamine in the presynaptic neurons. So it inhibits the transport of these neurotransmitters and increase the concentration of dopamine and norepinephrine in the synaptic cleft. That's how it improves the function of the precortex. What are the things you need to check before you give methylphenidate? One is the thing is that there should be no hypertension, family history, hyperlipidemia, premature cardiac death, Marfan syndrome, cardiomyopathy. If you have any of these, you better be cautious when giving this drug. So history of family history of cardiovascular disease is absolutely important. You must check that before you give methylphenidate. Psychosis is a contraindication. Tic disorder is a relative contraindication, and especially if you combine the drug with anti-drug drugs, like if it is severe enough with risperidone or haloperidol, you can give methylphenidate. Seizure disorder, sometimes they say it's unmasked seizure disorder, but it doesn't usually happen if you're on proper medication, except don't use the older medications like phenytoin and phenobarbital in these children. And structural abnormalities like heart disease, that's very important. If you have Kawasaki disease, rheumatic fever, families from Marfan, sudden death can be happen in children on methylphenidate. Pre-existing hypertension is another contraindication, and concomitant use of MOA inhibitors is something that we must know. So it worsens tic, psychosis, anxiety, abuse potential, and fatigue and insomnia. So these are things that we must know before you start methylphenidate in a child. What are the different formulations of methylphenidate available? One is the immediate acting. The action for immediate acting methylphenidate is 4 hours. The action of the sustained release tablets is 6 to 8 hours, and that for the control release tablets is about 12 hours. So that's something that we must know. The 12-hour medication has the methylphenidate is the same dose throughout the day for 12 hours. So that's something that could be used. It's a little costly, but four times costlier than methylphenidate per se. So these are doses which will be available in the formulary, and this is how we would do the doses for the long-acting or the sustained release, control release tablets. What are the things you need to follow up in children on MPH? What about eating? Why do the children on MPH not eat too well? They have anorexia is a problem for these children. And why do they not eat? Because it's stimulation of the activation of the insular lobe that generates disgust sensation. So they have a disgust sensation to food. Increased activity of the mesolimbic reward pathway and elevated extracellular dopamine in the nucleus accumbens makes the child feel full, so he can't eat. These are two things that you must realize, that children with MPH will have a problem with sleep. Now, in most clinical studies, you find that this anorexia subsides in about 6 months' time. So if you continue to give methylphenidate in these children, sometimes after some time anorexia subsides. Most of these conditions, you can wait for some time and see if the anorexia causes a problem. But if it is affecting his weight gain, which you must check out with every visit, you must consider other measures. So the problem sometimes releases in a few weeks' time, it sometimes subsides on its own. So you can have a wait and see approach, check weight gain every visit. If the problem persists, then you take action. What are the actions that you could take? First, observe the eating patterns of the child. You could give the medication, food when the medication is least effective. The 4-hour medication, if you have the breakfast before you give the drug, probably in the morning at 8 a.m. before you give the breakfast, maybe he might eat well. 4 hours later, when the medication is less, you know that the small acting medication lasts for 4 hours, so after the 4 hours action, the medication is less in the blood, maybe you can feed. Or in the night after the evening dose. So it's important that you give it when the dose is minimum in the blood. So you should know the duration of medication action for each of these drugs. Other strategies would be to eat a lot of high density food, like you can give oil containing food, so that it gives more, it boosts, it helps to improve his calorie intake. So calorie dense food is important, and if this approach don't work, then different formulation of MPH or other brand. Sometimes you find that if you use Advice as one of the brands and it doesn't work, you try to Inspiral, it works. So some brands you can change, and the brand change might help reduce anorexia. And if it still doesn't is not effective, then you go on to the non-stimulant drug like atomoxetine. What about sleeplessness? Why does sleeplessness occur? many children with ADHD experience pre-sleep problems, and this is probably exacerbated by the methylphenidate. Methylphenidate is supposed to stimulate this, makes the child more aware, and therefore, because it becomes more alert, it can cause sleep problems, and so you must be aware that increases dopamine and norepinephrine, and this causes a wakefulness and with higher doses. So you can decrease dose for sleep and sleep disturbances. You could reduce the dose. So when most children with sleeping difficulty, you have to ensure that the medication is not given later than 5 p.m. in the evening, so that sleep is not affected. But you must remember that there are some slow metabolizers where you might find that you give a dose at 4 o'clock and the child doesn't sleep at all, because that child may be having a slow metabolizer, and so you must be careful about that. But other children are kept awake at night by lack of medication. This is something that we must understand, that when the medication is stopped, the brain doesn't turn off, and therefore you have the paradoxical reverse response to a stimulant medication. So when you're using methadone for a long time, you'll find that sometimes the children don't sleep well because the brain is working at the same pace after the medication stops in the blood. Reduce the levels of the blood, methadone reduces, the brain continues to work at the same pace and the sleep is disturbed. So you give a small dose of methylphenidate even at 8 o'clock at the night, small dose, and you try that for 2 weeks, and if it helps, it means the child is going to be benefited by giving methylphenidate late in the night. So that's important. The paradoxical response to methylphenidate is something that we must realize that could happen. And so when you use this drug very often, you'll find that some of these children will require a small dose of methylphenidate in the night to fall asleep. So there's no easy way to tell which scenario explains the child's problem, and therefore trial and error method, you must check out whether this 8 p.m. dose will be effective. And if it helps, then you must continue this 8 p.m. dose and a smaller dose. Other options that may be tried are some stimulant medications that's not strong enough to overcome the severe restlessness of the ADHD, and therefore the standard response which happens is to directly lower the hyperarousal component of ADHD by using alpha agonists. So if nothing works, then you can go on to try FDA approved drugs like clonidine or buprenorphine. Clonidine can be tried if the other works do not work. Methylphenidate and tics. Now, this is something that we have already mentioned, that tics, if you are on proper dosage for control of tics, maybe it might not be a contraindication to giving methylphenidate. But if you start methylphenidate, if tics start, you realize that it's not tics. Most potent trigger for tics is caffeine. So you stopped caffeine for 2 weeks and see. Tics sometimes resolve in 2 weeks' time. It's a 2-week cycle for tics. You can you can continue the medication and wait and see if tics subsides by itself. So this wait and watch approach can be tried. You can stop caffeine, tea and energy drinks, and that might help. And almost half these children lose their tics without stopping the methylphenidate. So that's important that you try these out before you try and stop methylphenidate. If not successful, you can try trial of clonidine, which lowers the tic to the point that is no longer disruptive or embarrassing. You can try clonidine. Other problems are rebound hyperactivity. Rebound hyperactivity is something that you must realize could happen when using immediate acting or short acting methylphenidate. Sudden increases in the levels of methylphenidate and sudden decrease will make the child hyperactive again. So rebound hyperactivity is known to occur with short acting methylphenidate. And so what you do is that you could either reduce the dose of immediate acting preparation, which causes a rebound, or you can change over to a long acting like sustained release or controlled release tablet, which will maintain the levels of methylphenidate throughout the day and prevent this sudden rise and reduction in the levels of methylphenidate. So that's something that you must try. Headaches is another common problem with methylphenidate, and you must remember that headaches go away several weeks into medication. So this also will, if you continue the medication, the headache might subside. But sometimes the medication is not due to the headache is not due to medication, but because of dehydration or giving MPH on empty stomach, where the levels decrease. So this is something that you must remember, that hydration is very important, and you can reduce the dose of the short-acting methylphenidates, or if this does not work, then you try other medications. Others are dizziness, dry mouth, moodiness and nausea, which also are problems with methylphenidate. Emotional problems with a dosage too high, stimulants can cause children to act like zombies. So they can become tearful and irritable, and therefore lower the dosage. If they become like zombies, sometimes they can, though the methylphenidate is supposed to make the child alert, high doses can make them look like zombies. So that's something we must realize. And if reducing the dose of dosage causes ADHD, then try the sustained release or the control release tablets. And if all stimulants work, don't cause these problems, then you change over to non-stimulant medication. So it's important that you know how to use a medication, what the follow-up should be, and how do you adjust the dosages, and what do you change the drugs when required. So you give a trial of 6 months, and if it doesn't work in all these methods that I've mentioned, then you must think of a different alternate diagnosis. So that's something also that you may have to stop the medication and look for an alternate diagnosis. Anxiety and depression are also 25 studies have shown that child comorbidity of ADHD is anxiety, and stimulants are similarly added to augment the treatment of depression in some cases. So when you give the stimulant, sometimes anxiety also decreases, because when you treat the ADHD, a lot of this anxiety decreases, and sometimes it also may worsen mania. So that's something that we must keep in mind. Atomoxetine is the other drug. The mechanism of action is very unclear. It probably is related to selective inhibition of presynaptic norepinephrine reuptake in the prefrontal cortex, increases both norepinephrine and dopamine levels in the prefrontal cortex. Now the dosage is that, and the problems with side effects. Atomoxetine, the advantage is that you don't have to have it's not a scheduled drug, and so you don't need to give 2 prescriptions for giving the drug, and very few pharmacies have this license to dispense methylphenidate. That's a problem. Atomoxetine is given can be got over the counter, and the action is similar to methylphenidate. All the complications and side effects are similar, but appetite suppression and initial weight loss could occur, with the exception that it worsens insomnia. You could have, it does not worsen insomnia. It can actually cause a little bit of sedation. So if you give it in the morning, the child might sleep through the school time. That's a problem. It causes drowsiness. That also will decrease with time. So if you continue to give methoxamine for some more time, the drowsiness might subside, but it can cause a little bit of unbearable drowsiness. Others are dizziness, lightheadedness, and fainting. When you compare MPH with atomoxetine, all studies have shown that both of them are effective. The only studies that have shown that the control release tablets are maybe slightly more effective than atomoxetine. Otherwise, some children do better on methylphenidate, some children on atomoxetine, and it depends on which drug the pediatrician is more comfortable with. You could use both. What about autism? Do I have some time? Okay, autism. As we know, there's no efficacious treatment for the core symptoms of autism, and the AAP and the IAP has suggests that you target one or more of the problem behaviors when considering medications in autism. Don't give it, because it doesn't take care of the core symptoms of autism. So the studies have shown that the difficulty in assessing the effect of pharmacotherapy in autism is that many symptoms are there, many core symptoms, many of the comorbid conditions are there. So if you give one medication, it helps in one area of autism, it might worsen another. So it's very difficult to assess whether the drug is effective or not. Most clinical trials have very poor results. But Dr. Shefali Gulati and team have found that if you have a CARS improvement of 4.5 points, it might mean that the intervention is effective. So on therapy, if there is an improvement of the CARS by 4.5 points, maybe it may be effective. And unless we have biomarkers for autism, proper biomarkers, it's very difficult to assess the treatment of autism. Well, this slide will tell you all the recommended dosages for drugs for autism. The most studied is risperidone for irritability and aggression. It's both are and aripiprazole, both are FDA approved. And risperidone, the problem is that it can cause sedation and increase weight gain. So that's a problem. But that is the only drug that you can give in small doses if there is aggression and irritability, and sometimes with aberrant social behavior. The oxytocin nasal spray is being tried. Hyperactivity already mentioned. Methylphenidate. Methylphenidate for ASD should be given as a smaller doses than usual. If you give the same doses as for ADHD per se, you'll get more problems. You'll get more hyperactivity and more side effects. So they found that if you give half the dose or even 1/4 of the dose that you give for normal ADHD without ASD, the results with methylphenidate is about 80%, but with ASD with ADHD, the results are only 50%. And if you give it a small half, 1/4 or 1/2 of the dose that you use for ADHD alone, you might get good results. And even joint retention is improved when you give methylphenidate. Atomoxetine has been used only for the high functioning age. There's only one study on atomoxetine ASD with ADHD. Repetitive behaviors and depression, you can try fluoxetine, and these SSRIs also 50% improvement in repetitive behaviors are noted with when you give fluoxetine. Cognition, memantine and rivastigmine have been tried, and insomnia, of course, melatonin is maybe tried for short duration. All these drugs in ASD should be given only for short durations and maybe reduced as soon as possible. Melatonin is used as it reduces the latency to sleep. That's it. It doesn't do anything extra. So it's not a great drug. It only reduces the latency to sleep. Suppose a child has 1 hour to sleep, it about reduces it by about 20 minutes, 30 minutes, the latency to sleep. But so it's used as a sleep regulator for about 2-3 months, 2-3 weeks, and then reduced and stopped if possible. And other sleep hygiene, other things should be considered as a possibility. Depression in autism is very difficult to diagnose, as we already mentioned, because the communication deficits are typical presentation of ASD, and standard diagnostic tools are not available, and therefore it's very difficult to actually diagnose depression. And so depression would be diagnosed if there is sudden changes in the behavior, screeching and crying a lot. If a child is not responding to treatment that is normally response to things, maybe you might consider depression. And there again, SSRIs are useful, but clinical suggests that they are useful and generally useful on a case-to-case basis, but it can cause behavioral reactivation, irritability, akathisia, and sleep disturbances. So this is something that we must consider when you're using SSRIs in children with ASD. Mood stabilizers may be tried in ASD if there's irritability and mood liability, impulsivity, seizures and manic depressive symptoms. You can try mood stabilizers and valproate or divalproate, carbamazine, oxcarbazine, lamotrigine, and lithium may be tried. Anxiety I will not deal with, spasticity I will not deal with at all. Thank you so much. Before I finish, I would like to say that pharmacotherapy has a limited role in NDDs. Importance of detailed counseling is very important. You must get everybody understand what the reason for treatment, how long it's going to be treated, and what the goals are. Start small and increase slowly is very important. Know the indications and contraindications of various drugs that are prescribed. Know the effects and side effects of these drugs. Decision of stopping and changing drugs should be, you should continuously monitor. You know these drugs well, and you must know how to monitor these drugs and how to adjust the dosages over time. And when you have a prescription that contains 10 to 15 drugs, when you come, some patients come with 10 to 15 drugs, 3 for sleep, 4 for depression and things like that, you should be able to reduce the drugs gradually over time, not suddenly stop everything, because the parents have got some relief with some of the drugs. It's important to decide how to reduce these drugs and how to decide on what are the symptoms that you need to treat and which drugs will be useful. Thank you so much.
Thank you so much, sir. Actually, you have covered the main important side effects of the problem with the practicing pediatrician is they come with the side effects. We don't know how to counsel them. Thank you so much for such an elaborate description of the side effects and how to manage them.